70 million people who are visually impaired. That's the size of a country. What are these visual impairments?
When we talk about India as a whole, the cause for blindness, cataracts still qualifies as the primary cause.
If you look at the history of blindness in the country, in the 1980s, there was this massive drive which started for correcting of cataract specifically.
In the 80s, cataract was way more than what we're talking about. India implemented district blindness control programs across all states, and they were able to address mass cataract surgeries with low-cost surgeries. So that changed the game. Diabetes is a chronic condition, affects the eye in varied ways, and one way in which it leads to blindness is retinopathy. To treat diabetic retinopathy, you need very expensive equipment. Even if you do have this capital expenditure available in a rural setting, you need expertise to treat these patients. Even if you are able to set it up at multiple locations, how will you sustain it? How do we take treatment for diabetic retinopathy to the rural community is the challenge now.
If you can actually tell us these 3 or 4 main disorders, what causes cataract, what causes diabetic retinopathy? Hi, I'm RamG Vallath from RamG Foundation. In this show, we bring to you stories from the world of health. These are stories from the frontline, stories of path-breaking work. So sit back and enjoy. This is The Health Worker. Dr. Krishna is going to take us through a terrific innovation which has changed the lives of so many thousands of people in the country through a mix of
Technology, innovation, and collaboration threw up a unique solution for a complex problem like diabetic retinopathy.
Wow, fantastic. So Krishna, 70 million people who are visually impaired, that's the size of a country. I just want to know, what are these visual impairments? What are the Pareto of that? What are the main ones? And if you can just throw some light for all of us.
Ramji, you touched upon, actually in your introduction, you did touch upon 2 terminologies. One was blindness, and the other one was visual impairment.
Mm-hmm.
I think it's important for us to put these 2 terminologies in context.
Okay.
So when we talk of blindness, it is a person who has vision of less than 3/60 in the better eye. So that is blind.
Okay.
That is a definition of blindness. Whereas when we say visual impairment, that is, it may not qualify as blindness, but it is still significantly affecting the livelihood of a person because of low vision. And this is again defined as anywhere between 6/18 vision to 3/60 in the better eye.
Okay, now I have no clue about what you said about 3/60. If you can actually just explain that to us better.
So 3/60 is what a normal individual would read at 60 meters.
Okay.
A blind person needs to go up closer to about 3 meters.
3 meters. Okay. So for a normal person, it's 60 meters. For a blind person, they have to go as close as 3 meters.
3 meters to see the size of those objects.
Okay, that's very clear now. Yeah.
So when we talk about blindness, now the WHO has come up rightfully so that we shouldn't be talking only of blind people. Mm-hmm. We should be talking of visually impaired as
also.
well, because livelihoods are affected. So that's where the numbers come. The numbers you just rolled out, though they are staggering, daunting challenges for the healthcare system, no doubt. And it's not something that we need to be proud about either.
Yes.
So because they are huge numbers, and these are people at the end of the day we're talking about.
Yeah.
When we talk about India as a whole, the cause for blindness, that is less than 3/60, cataract still qualifies as the primary cause for blindness in our country. It is followed up by refractive errors, corneal opacities, and then glaucoma. And then you have the new kid off the block, which is the non-communicable disease-related, diabetes-related blindness, which we see, which is called diabetic retinopathy. So these 5-6 causes take up the chunk of the
There must be 90%
blindness.
plus of
90% of the blindness that we see with us. When we talk of visual impairment, refractive errors takes the primary position.
Sure. Yeah.
So here they're not blind, but they are impaired with their vision. And this is again very easily correctable.
Yeah, but if you look at the history of the of blindness in the country, my understanding, and correct me if I'm wrong, is that in the 1980s there was this massive drive which started for correcting of uh, cataract specifically, right? I mean, there was a huge drive which happened. I remember those days when I was very young, and that really corrected substantially one of the issues which was there.
True, actually, because it's actually a very well organized program. It's called the National Program for Control of Blindness and Visual Impairment.
Okay.
So, NPCB and VI, that's what it is. So, under this head, the government of India and the state governments following which have actually instituted many very good programs, to address specifically the most important causes of blindness. And like you said, in the 80s, where cataract was not it was nothing like what we are talking about. It was way, way more than what we are talking about. We have come a long way in where we are these numbers, though they are big. They were much, much bigger then. And specifically to address cataract, India implemented this program where district blindness control programs across all states. And they were able to address mass cataract surgeries with low cost surgeries.
Yeah.
So that changed the game. And you had very important players who came into the picture as well at that time. Both the government as well as the non-governmental sector pitched in equally, if not more, in fact.
More, actually, yeah.
So they were able to the entire backlog of cataract blindness was brought down significantly. And now where we are right now, we're not talking about backlog, we're only looking at replacement, and which is still a big number, but I think we are very, very comfortable position as far as cataract is concerned when it's mass blindness. Apart from this, there are few other very successful stories. If you look at it in the 80s, 70s and earlier, trachoma was a very important cause of corneal blindness. Trachoma is actually it affects the eyelids.
Eyelids. Okay.
Eyelids. It starts from the eyelids.
Okay.
And because of the damage to the eyelids, it starts damaging the cornea after that.
Okay.
So it's an infection. It's caused by an infection. And trachoma was a major problem, especially Rajasthan and some areas in the northern part of India, even south as well. But with specific programs aimed at eradicating trachoma from our country, I think very recently India did announce that we are now trachoma free.
Oh, that's phenomenal.
So blindness because of trachoma is out.
And trachoma, the treatment is what? Medication?
So the medications for the early part of the disease is, the infection is controlled with medications. But once the damage has already happened, the chronic damage has already set in and it has affected the cornea and other places, there it has to be done with corneal replacement, keratoplasty and things like that, and lid surgeries. So those are more about trying to manage the end problems of early infection which has set in. So I think that we have come a long way. This is one specific drive which has totally led to elimination of trachoma. So that's a huge success story as far as India is concerned. Cataract is again a very good success story. And many other countries, southern countries are following the cataract model which India has developed. India has developed. And the surgical technique also has gone through a huge revolution with the impact of small incision cataract surgeries, the quality of surgery, the cost of surgery, as well as the the time for surgery. All that has come down.
This is even, in fact, in a case study, right? How the time for each surgery was brought down drastically. The doctor's time was saved by all preparatory work being done by others, and the doctor actually doing it almost like a mass production.
Yes, and sutureless surgeries. So even your manual small incision cataract surgery, with what we call, the time which was spent in suturing a wound was totally taken out.
Okay.
The steps involved in the surgery were very much simplified.
Okay.
And the whole globe, without having to open the eye, you could perform the entire cataract surgery, brought so much more control into the surgery, so your complication rates came down. So I think it has all added up. The technique part has added up, the public health drive has added up, and the delivery of care, the way in which it got spread out in the form of camp models. At that time, it was camps.
Yeah.
So go to villages, identify people with cataract, bring them all back to the main hospital, operate, and send them back the next day. It was excellent and it worked very well and still continues to work well. But again, a caveat here is that cataract is a one-time intervention problem.
Right.
So this program worked so well because cataract was a one-time
Yeah.
intervention.
And you could reverse the entire problem.
Yes, and you
by-
could reverse
yeah.
the whole blindness, and so this is a totally avoidable cause of blindness, and it would be completely reversed once you treat. So the results are also equally gratifying. That's one of the reasons.
So I'm going to sort of interrupt you here. If you can actually tell us these 3 or 4 main disorders, what is the cause of each of those? What causes cataract? What causes diabetic retinopathy? If you can just...
So cataract, of course, there are many environmental factors which add to the cataract, but the most important being that aging. So it is an age-related condition. As we age, our risk to develop cataract significantly increases. The cataract, when we define cataract, what is it that we're talking about? When the eye is in such a way that there is a lens inside the eye, which helps us focus the rays of light onto the retina as it falls in. It's a convex structure and it is transparent, crystalline, transparent structure.
Right.
With age, so when I say crystalline, that means it's made up of certain proteins,
Right.
crystalline proteins.
Right.
So with age, all proteins undergo modifications.
Sure.
So age-related modifications are inherent to proteins as they go through. So there are going to be some amount of translucencies and opacities which develop. The transparency of this lens structure is maintained largely because of the crystalline proteins which are aligned in a particular way.
Right.
And the minute they start, little dysregulated, misaligned, then you have the opacities which start developing in. And any opacity in the lens is classified as a cataract.
Okay.
So it's not a disease per se. So it's an aging process which is changes the thing. The minute it becomes opaque, the ability for the light to enter into the eye is now lost or obstructed.
Right.
So basically, you have brought in an obstruction as like a screen.
Yeah.
So you remove the screen, it's going to perform once again properly.
Right.
So that's the reason why it's a one-time thing. You remove the cataract, that is the lens which is opaque, you take it out, and you place a intraocular lens which is transparent. Most of the time it is a PMMA related
so a synthetic lens, basically.
Synthetic lens which is placed inside the eye, and it performs exactly like how the original clear lens used to perform.
And there are people like me who at a very young age had to go through this because I had to have steroids for one of my treatments. And so I developed cataract on both eyes.
Correct. So there are certain environmental influences, like I said. So excessive exposure to sunlight, radiations, medications.
Yeah.
Steroids is one of them, long-term steroids. Diabetics, uncontrolled diabetes, metabolic disorders. So there are other factors which influence cataract, but age still is the primary driver. When it comes to diabetes, so diabetes is a chronic condition.
Which is impacting about 16% of India's adult population
right now. And that's a huge number. Again, those are mind-boggling numbers. We call of, when we talk of that, it's another 100 million people that we're talking about who are suffering from diabetes in India. So diabetes affects the eye in varied ways, and one way in which it leads to blindness is retinopathy. Diabetic retinopathy is a late complication of diabetes. That means when a person is initially diagnosed with diabetes, he's unlikely to have diabetic retinopathy. It's only sugars which are high, and especially if the early detected diabetics. But as the individual lives with diabetes over a prolonged period of time, the minor insults due to the variations in the blood pressure, blood sugars which are happening, it does lead to damage to the blood vessels within the retina.
Okay.
We're just talking, it basically affects most of the small blood vessels or the capillaries that we're talking about.
Okay.
Retina is one such site of injury.
Right.
Kidneys are another site of injury like that.
Okay.
The blood vessels supplying the nerves of the legs are another. So we call that peripheral neuropathy. And when it affects the kidney, the nephropathy sets in.
Right.
But in the eye, it is visible to us. The changes which are happening is obvious to us when we inspect the retina. So this is diabetic retinopathy. And it actually is not something which just comes overnight. It is something which progresses slowly as a person living with diabetes lives longer. He's more likely to develop these late complications.
And their eyesight progressively deteriorates, is it?
So, the important thing about diabetic retinopathy is that in the early stages of the retinopathy, there is hardly any change in the eyesight.
Oh, is that right?
So the person is not aware that he is suffering from a condition called diabetic retinopathy till his vision drops. And the vision drops usually at the later stages of the disease.
Oh, by the time a lot of damage has
By
done.
that time, a lot of damage is done. And by that time, you're unlikely to reverse those changes as well. Again, these are chronic changes. This is like glaucoma. Most of these changes are irreversible. So that means you have to only contain the damage henceforth, but you cannot turn the clock back and bring it back to what it was, say, 4 years or 5 years back. So the importance again here of trying to pick up the disease at the early stage, and there are effective treatments available in the early stage before the patient has lost vision to maintain that vision at that stage. But that opportunity lost is when the patient comes to you with loss in vision. So the cost of treatment is hardly free for them. So he said, boys, look at a solution where these patients can access this care locally, where they can repeatedly come, take treatment and go back without having to waste money trying to come to a big city and spending on other miscellaneous expenses. So now we have a problem. We now have to look for the solution.
Mm-hmm.
How do we take treatment for diabetic retinopathy to the rural community is the challenge now.
Yeah.
The challenges are unique mainly because of these hurdles that you would face now. Is that one, to treat diabetic retinopathy, you need very expensive equipment, lasers, and they are very sensitive equipment as well.
Okay.
So you need lasers and the diagnostic set, which I was telling you about. It's huge capital expenditure.
Okay.
Putting this kind of a capital expenditure across multiple locations is not economically feasible.
Yeah.
Even for the numbers that you're going to end up treating. The second thing is, even if you do have this capital expenditure available in a rural setting, you need expertise to treat these patients.
Right.
So plain ophthalmologist is not trained to treat retinopathy.
Okay.
So that there is a retina person who needs to treat this.
So even somebody who can do cataract will not be able to do.
Will not be, because he has not gone through the training for treating diabetic retinopathy during his post-graduation.
Okay.
So he is incapable of treating diabetic retinopathy in the rural area, wherever he is. And the third thing was that even if you are able to set it up at multiple locations, how will you sustain it? Because as you go into a rural population, the numbers don't justify the investment that you're going to put in there. So these three being the challenges, we said, okay, what would be our solutions for this? And one solution which looked feasible, which came out, was that why can't we put one set of top-class equipment, super specialty clinic, and share it across multiple locations. So that would take care of our investment. One investment serving multiple rural locations, because this is not an emergency problem. People can be pooled in each of these areas and treated on a routine calendar schedule. So that was one solution.
So just interrupting you, what is the actual expense? I mean, how much is the quantum?
So generally a capex of about 1.5 crore is what you're looking at, which includes putting the entire equipment on a mobile platform. So this is what. So sharing, when I said, is that I have to put it on a mobile platform. So that it can be shared across multiple locations, because you have moving these equipment all over the place. So the entire capex would be somewhere around 1.5 crore, roughly, up and down. So this was one part of the solution, but we still hadn't solved the other issue, which is expertise. Where do you bring the expertise from? You are not everywhere. You cannot be in all the places to treat at the same time. So then the obvious solution which came out was that, why don't you leverage on existing manpower? Which is, many of our ophthalmologist friends have set up their own small clinics in smaller towns and cities by choice. So they're working there in smaller towns and cities. Their main bread and butter is still cataract and glasses prescriptions and other things. But what if we can train them to deliver this retinopathy care? So then they become your foot soldiers to deliver the care that you want to be delivered in the rural areas.
In that area.
So for them, it is an upgradation from where they are. They're technically now sounder. They're able to handle cases which they were referring away before to a bigger town or a city. And they're able to hold on to their patient clientele. Because once it is referred off, they lose that patient. Once you treat that patient, he is perpetually a patient.
Yeah.
So his practice expands.
Wonderful.
He is able to deliver the care now. In the eyes of his peers as well as the patients, he has gone up a step. He's able to
Absolutely.
deliver
Yeah.
specialty care.
Yeah.
Now the facilities the equipment which he needed to deliver this care is
Yeah.
being made available to him on a monthly schedule.
Right.
Once a month it's available to
Right.
him. So now we have a setup where you have specialists who can handle diabetic retinopathy in rural areas.
Okay.
On one day in a month, they become a specialty clinic, treat diabetic retinopathy.
Okay.
And this schedule is known to patients as well as to the doctor. It goes along a monthly calendar schedule.
Right.
So on that day, it's in that town and everybody knows. And slowly the word of mouth and the fact that you have local doctors there, it improves, and your patient acceptance and patient coming in for treatment also increases.
So now you must have treated for the last how many years has Nayana program been going on?
So Nayana program started in 2005. So we are 20 years,
20 years,
into the program, and
Wow.
it is still functioning.
Okay.
Of course, it has morphed itself a little bit, but it's still functioning well. And we have treated about 55,000 patients with diabetes-related problems on the van.
Wow.
So the van is totally self-sufficient. That means it carries its own power. There's a treatment chamber, everything there. So even if there is no infrastructure available in those areas, it can still independently function full time.
Right.
So we've treated about 55,000 patients on the van, screened more than 65,000 patients,
Terrific.
and it's been a good journey, actually, learning journey.
I think
for
this is the
us.
most amazing innovation I have come across. And you said this is unique in the world, right?
So it was the first at that point in time. That was the first of these this kind of an innovation. But the World Diabetes Foundation, which initially seed funded us for this program,
Wonderful.
we should I think I'm in line to compliment them for
Yes.
having put faith in a group of youngsters who had no credibility whatsoever, coming with a fantasy idea.
Fantasy idea.
And saying that we will pull it off, we'll pull it off. And they actually funded us for this and trusted us to deliver. But what happened was, in 3 years' time, they saw it as their star program. And they
They took
said,
it across.
yes. And they said, can you help us replicate it across the globe?
Yeah.
And now Nayana has been replicated in 17 other locations, 9 countries outside India. So including Tanzania, Sudan, Fiji, and Thailand, Bangladesh. So a lot of places where people have come, trained in both programmatic training as well as technical training in the medical field,
And gone back.
gone back and set up, and WDF has gone in and funded them for that.
Oh, this is wonderful. What a inspiring story. So many thousands of people owe their eyesight to this program, right?
I think so, because I'm not sure how many of them would have actually made it to the
From
bigger
your
cities.
initial experience
Very
of
few.
700 people completely dropping off the map, obviously many of them would never have actually.
Yes.
Now, I'm going to ask you one more thing, actually. Diabetes has to be caught early enough, right, for you to be able to treat properly, right? So if there is a diabetic retinopathy, it doesn't show up
Correct.
Immediately in the vision.
True.
So how do you ensure that people who are not having a visual impairment still are screened for this problem?
Exactly. So that's the next step of the problem, was that screening is the important bedrock on which any diabetic retinopathy program has to function.
Right.
And screening means that every single patient with diabetes needs to be examined for his retina for diabetic retinopathy once a year.
Right.
So that is mandate.
Yeah.
There's no shortcuts for this.
Right.
So what we had delivered was care.
Right.
That means once a diabetic retinopathy has already been identified, we saw how we could take the treatment locally. So we worked backwards.
Right.
So we had taken the problem of treatment and started from there. Like I said, Nayana has morphed a lot after that. And what is the morphology is that, what is the change in morphology is that we have included a very robust screening program to this to feed to your treatment apparatus that you have set up now.
Okay.
To make it more efficient, you need more people to access this care. So this is where screening, again, we're using technology. Teleophthalmology has been a big boon with very, very innovative fundus cameras and low-cost fundus cameras which have come in, with which you can take photographs of the retina of
Okay.
these patients with diabetes,
Okay.
for which you don't need a doctor. You
Okay.
only need a technician who can take images of these retina.
Okay.
And we have our own software as well now, but there are many other on the available on the shelf. So these images are uploaded
Okay.
and they are graded by graders to see who
And
has
the graders who sit in a central location.
central location. It could be anywhere.
Right.
Because it is
It's
cloud
on the
based.
cloud, yeah.
So it could be even a local grader, or the person imaging himself can grade it, or it can be sent to a location where trained graders can grade it, and then it triaged. Many of them don't need the treatment.
Okay.
They only need to come back a year later. So
Right.
those can be weeded out post screening
Right.
through teleophthalmology.
Yeah.
Those who have a problem only need to reach the doctor.
Okay.
And that is where, once you pick up those with sight-threatening retinopathy, are escalated to the van.
Okay. Got it.
So screening happens independently. Now the van has the treatment equipment. Only those who need treatment needs to reach out here. So that's the most important thing, is how good your screening program is. If you have a very efficient screening program, you will have to do, you would have tackled your diabetic retinopathy problem very effectively.
So, so for this, you must have had to tie up with places where people with diabetes come for treatment, right? Not ophthalmology places.
Exactly. I don't know. RamG, I think you have studied this thing much more closely. I only
I've
learned
become
through
an expert.
experience. I only learned through experience. But yeah, but what you're saying is spot on.
Right.
So that's where, when you start screening, there's no point in screening wherever you want to.
Yeah.
You identify places where there is a congregation of patients with diabetes.
Right.
So which are these congregation points? These are where they get treated for diabetes,
Okay.
which is a diabetologist's clinic.
Right.
In our health setup, if
Yeah.
you look at it in the government setup,
Yeah.
there's a very beautiful program for non-communicable diseases,
Right.
where most of the all the taluk hospitals, in fact, and many primary healthcare centers as well,
Right.
have got what is known as a NCD clinic, or non-communicable
Yeah.
disease clinic.
Yeah.
So these are local patients with diabetes, hypertension, stroke, cardiovascular diseases, and cancer. So these are all clubbed together, but it's largely diabetes and hypertension, who are enrolled into these NCD clinics, where they get their monthly dose of medicines
Yeah.
free of cost.
Yeah.
So they come there regularly to
Yeah.
collect their medicines and go back. So this is one obvious congregation point for diabetes to
Right.
repeatedly visit.
Right.
And I think it's also a very opportunistic place for us to start our screening there.
Correct.
Every diabetic who visits the NCD clinic, even if he misses one screening date, he can be screened on the next visit.
Okay.
So that way you effectively push your screening program through the government programs which are already there, and increase the kind of screening ability right up to the last man.
So you have a technician who is carrying this camera and going to each of these places where the diabetes treatment happening.
Yes. So the technician's job is, he's going with a small handheld camera
Yeah.
and a laptop.
Yeah.
And so basically, laptop carries the electronic medical records for us.
Right.
So all the data about the patient is entered there. Images are uploaded into his electronic record, which is created, and that is uploaded. So what the EMR does for us is that not only does it help us to deliver the care, but the EMR is designed in such a way that it helps us to ensure compliance. That means if a patient was identified with sight-threatening retinopathy but didn't make it to the van,
Yeah.
flags off. So then
you follow up.
follow it up again, ensure that he gets. Second thing is, after treatment, there's always a follow-up appointment which is scheduled with every patient.
Right.
So suppose I treat you, but I said once in 3 months I need to see you again. If you don't turn up after 3 months, it flags off.
Right.
So it not only ensures efficiency in completion of treatment protocols, but also increases compliance rates to follow.
Wonderful.
Which is the biggest problem in India, is compliance to follow.
Absolutely. Yeah. Yeah. And how many such centers does the technician visit?
So presently we are covering 8 districts of Karnataka.
Wonderful.
And among which roughly about 28 or 29 centers where screening is happening, and treatment happens at around 23 locations. So there are some locations where screening is clubbed to one treatment center.
Yeah.
That's
wow. So these would have been people who would never have had the opportunity to get diagnosed or screened, diagnosed, and treated, who are now getting this treatment, and many of them free of cost.
All of them free of cost.
All of them
now-
free of cost.
So right now we are working within the government centers.
Oh, yeah.
So we don't charge there at all. So
Wow.
wherever it is, the diabetic program is happening is all free of cost because in government centers we don't charge anybody there.
They're truly inspiring, my friend.
Thank you, sir.
So, Krishna, in this entire narration of Nayana, you've emerged as a hero, by the way. And I think even bigger hero is your father. So, every hero has an origin story. I want to understand how your family got into doing so much of charity.
Before I go into that, I think it is my duty to put it in the place here that the original conception as well as the implementation was largely my dad's
Yeah.
idea. And my elder brother was the person who started this program.
Wonderful.
I probably inherited it after some time and ran it for a long time. So I think that initial compliment of yours, I think they deserve it more than me.
So, family of
thank you-
heroes.
But thank you very much. Thank you very much for that recognition, though. So, going back to our family lineage, we've been a family which has been involved in ophthalmic care. So, I'm a fourth generation ophthalmologist myself, fourth generation myself. So, the whole journey, if you trace it back, runs into the late 1800s, early 1900s. My
Wow.
great grandfather was one of those first few Indians who traveled to the UK and trained himself in ophthalmology and came back to India. And he served under different governments, different rajas. At that time, it was princely
Yeah.
states, and in different capacities. He had a very, very illustrious career in his medical profession. And later on, he settled down in the Mysore state. He
Mhm.
was the personal physician of the Maharaja of Mysore. He was one of the founding members of the Bangalore Medical College, and he was the first principal of Bangalore Medical College as well.
Okay.
He was a superintendent. He served as superintendent of Minto Regional Institute of Ophthalmology. So he had a very, very successful medical career. He was a doyen in ophthalmology as well. After his retirement in 1940 from all other services, he started his private practice, and he
Okay.
called it the practice,
Okay.
which we today call as Prabha Eye Clinic.
Prabha Eye Clinic.
So 1940, he started that, and he ran it very successfully for some time. And then he was, again, this practice was inherited by my grandfather.
Okay.
Grandfather was his son-in-law.
Okay.
So my grandfather took up Prabha Eye Clinic, and he was a very, very self-made man. My grandfather, he came from a very modest background
Okay.
and worked very hard to go where he went. Very disciplined man. And he built Prabha Eye Clinic into a very good brand. And at that point in time, there were hardly any specialty eye clinics in the private sector.
Right.
My grandfather was joined by my father, who again went to the UK, trained himself in ophthalmology, and came back and joined my grandfather sometime in 1971. And together, between my grandfather and father, they took Prabha Eye Clinic to very great heights.
Same
Luckily,
thing.
both of them had the same mindset. Somewhere around 1980s, 1988, it was. Father felt that, look, if at this present moment we are doing it as our personal capacity,
Right.
can we take it to a bigger scale, the philanthropy part? Can
Right.
we take it to a bigger scale? For that, it need not be ad hoc, it has to be more organized. And that's when the Sri Keshava Trust was formed to carry forward the legacy of philanthropy into a much larger space.
Okay.
And not just at a personal level, but to involve community as well. So for that, you need to have a platform in which the community can participate as well. So that's when the Keshava Trust was formed. And under Sri Keshava Trust, Vitala International Institute of Ophthalmology is the one which delivers the eye health care. So we are three brothers. Praveen,
All
my elder brother.
ophthalmologists?
Vinay is my younger brother. My wife, Kalpana, she's also an ophthalmologist. And my sister-in-law, Gauri, she's a glaucoma specialist. She's also an ophthalmologist.
The family with a vision.
Yes, and now we are a bigger team within the family as well. And so we've been very, very lucky, I would say, that we have been able to inherit such a wonderful platform on which we have been able to paint our own ideas on a wide canvas.
Wonderful. Wonderful story. Thank God that somebody had the vision to start something like this and then take it to the level that it has. So I just want to understand a little more now about India's public health system. So you mentioned uh, refractive problems, then you mentioned uh, cataract, then diabetic retinopathy, glaucoma, some of the big ones, right? What is our public health system? How is it geared up to handle each of these things?
See, India has a very, very uh, robust public health infrastructure.
Yeah.
So I'll say a very robust public health infrastructure which penetrates right up to the village as well.
Yeah.
So the government is the biggest player here. But where we lack is efficiently implementing care through this infrastructure. That is where I think there's a lot of scope for improvement, is that the infrastructure reaches there, but unfortunately the care is not there as we would have liked to envisage it to be.
Yeah.
So I think that's one place where a lot of work can happen and produce excellent results from there on. That being said, India also has a very, very vibrant non-governmental
Yes.
public health infrastructure.
Yes.
Especially in eye care. So I will restrict myself to eye care,
Yeah.
and there it's one of the best across the world. Such a vibrant non-governmental public health infrastructure which is there, and that's one of the reasons why when we look at cataracts or refractive errors that we're looking at, though the the permanent infrastructure is better off with the government, when it comes to efficiency in delivering this care, the NGO sector works much better.
Yeah.
The numbers speak for themselves there. And that's what I was saying is a point where a lot of improvement can happen, and it could even take the entire healthcare
To the next
infrastructure to the next level itself. Cataract has been sorted out to a large extent. It's only about pockets which are, the blind spots which need to be addressed. But I think most of the other problems have been sorted out with cataract. Refractive error also has got a very, very robust program now. And the new school screening program, which has been more or less mandated as law, that every child entering school has to be examined for refractive errors.
That's
So
wonderful.
that is, I think, an excellent entry point, ideal place to pick up the refractive error early and then, give it. And every year, every child needs to get screened. So it's only the implementation part which is lacking in some places, but by and large, I think it is something which is improving by leaps and bounds every year. When we come to the non-communicable disease problems, we said diabetic retinopathy is a big problem, glaucoma is a big problem. This is where the public health infrastructure is not geared up, unfortunately.
Okay.
For the kind of problem that we are facing, we are not yet there.
Right.
For the simple reasons which we just explained and discussed right now, that it requires a slightly different strategy for which the health infrastructure is not geared itself for.
Yeah.
And I think that is where our biggest pain points are going to come from now, is the number of patients with diabetes who are going to end up with blindness.
Yeah.
And though the basic health infrastructure of medicines and things are there, the complications of diabetes are still not addressed at that level. It is happening ad hoc, it's happening sporadically, but it's not through a proper program where every complication is picked up. And I fear that will be our biggest challenge over the next couple of decades, of how we're going to handle the fallout of all these diabetic patients who lived for 10 years, 15 years, 20 years, who are going to come with complications.
Wow.
And there I feel is where we should be stressing our resources on.
Yeah. So, there's some back of the envelope calculation I was doing. If assuming 10 to 12% of India's adult population, then some people say it's as much as 16% are diabetic, and about 20% of them develop diabetic retinopathy, and about 20% of that become blind. That's a huge number we are dealing with. That's millions of people.
Millions of people. Millions of people. So, like you said, 100 million already living with diabetes, and about 4.55% having sight-threatening diabetic retinopathy. That's you already have your numbers there, which is present numbers. And the extrapolated numbers are even more mind-boggling.
Yeah.
With every year.
Because the numbers are going up. Yeah. Okay. So screening for refractive problems at the school, cataract is sort of in place. There is expertise available, and the infrastructure is not substantially required. But the problem is in diabetic retinopathy, where we need to ensure that the screening, the equipment for screening is available at rural locations, or at least closer to the rural locations. And the treatment with so much of expensive equipment is also available in at least taluka places.
During our conversation, we missed out one small point, not so small when you look at the impact that it has, though, is that we've been discussing about most of the public health issues, but there is one disease which is very close to my heart as well, which is called retinopathy of prematurity, and which is a major, major problem as we are seeing it unfold in front of our eyes, which has a very, very high impact on society. This is again a disease which develops in premature children.
Mm-hmm.
Any child who is born less than 34 weeks of gestation or 2000 grams birth weight is at risk of developing a condition called retinopathy of prematurity, or ROP.
Okay.
So what it entails is that when the child is growing inside the mother's womb, at around 16 weeks of gestation, pregnancy, the blood vessels start growing in the retina from the center, and they start growing towards the edge of the retina.
Okay.
So this is the journey. This is the journey of development of the retina.
Okay.
Starts at the 16th week of life, or 16th week of intrauterine life.
Yeah.
And then it reaches the edge of the retina by about 38 to 39 weeks, which is full term, 9 months pregnant baby. Right. So there are many times where children are born much earlier than 9 months pregnancy.
Right.
So they may be born at 28 weeks, they may be born at 30 weeks, 32 weeks.
Yeah.
So what happens now is that you are left with a situation where the retinal vessels have grown part of the distance, and there is yet to grow some amount of the retina, which is yet to be vascularized, or blood vessels need to grow. So now you have a situation where half the retina is vascularized, the other half is not vascularized, but the environment has completely changed.
Correct.
What was the mother's womb, a protected environment, now it is thrown into the world, and it's breathing on its own. It's facing challenges in even survival. So all these complicates in such a way that this normal vascularization sometimes gets arrested. And it starts growing backwards or into the eye. So this is when the disease called retinopathy of prematurity starts developing. The good point of it is that if you identify it at this stage, where it's getting arrested and the disease is developing, you could do a treatment called laser photocoagulation and preserve the entire retina which has been vascularized. So vision can come back normally. However, the sad part is that if you miss this opportunity, in a couple of weeks, it reaches a stage where you can't treat it, or treatment is not really effective, or the child goes blind because of it.
My God.
Blind for life. So that's where the impact part comes, is that you have a disease, you know when it is going to develop, you know whom it is going to develop, because it usually develops in the first 2 months of life, after it's born. You know in who it's going to develop because it's a preterm babies.
Yes.
And you know the outcome, and you have a solution.
All it requires is a screening.
All it requires is you screen every single premature child from birth till at least 3-4 months of life, so that if you can pick it up and treat it, you make sure that the life changes for the entire family, in fact, not just the child.
So for about 2-3 months, every week, every 15 days?
Every 15 days, if everything is going normally. If the disease is appearing, then once a week. And
the treatment has to be immediate.
It has to be immediate. Within 48 to 72 hours, initiate treatment if the disease reaches a particular state of aggression.
And you again said laser, so it must be an expensive equipment.
So it's a same laser that we use for diabetic retinopathy, but it needs to be treated differently, in the sense that we are treating a child who cannot sit up and do so. The technique of delivery of this laser is slightly different. And these babies many times are, surviving in NICUs or on life support and things like that. So the treatment may have to be done where the child is being
within
treated,
the ICU.
Within the NICU, wherever the child is. So this is the biggest. We should not be sitting together 5-10 years down the line and saying what were the missed opportunities, because this is something which is happening right in front of our eyes. Babies are surviving, smaller babies are surviving in smaller towns, smaller cities, and the number of people who are treating retinopathy of prematurity are a fraction of who are treating diabetic retinopathy. So you can imagine the number of the gap in the required to the available is even more. And those who are treating diabetic retinopathy of prematurity are all sitting in the big cities.
Big cities only.
Yeah, they are super trained, so they are not.
So are you doing something in this area?
So this is where again technology has a big role to play, and we've been involved from about 2009 now in running a large outreach program called Vitala ROP program, where we've used what the learnings of Nayana have been incorporated into this program. So this is disease specific. We are screening every single preterm which are born in 14 districts of Karnataka.
Wow.
So around 14 districts of Karnataka, and many NICUs which have tied up with us. So, but here the frequency is once a week, not once a month as it was in diabetic retinopathy. It's once a week.
Right.
So 14 districts, once a week, every child who's there and this thing gets screened. And if we identify a child with retinopathy which requires some form of intervention, immediately a doctor with the laser machine travels to the NICU wherever we have identified the baby, delivers the care within 48 to 72 hours. And we continue to monitor the child till complete recovery. This is again, the software which we use is very much similar to what we use. So here the software was initially developed for ROP, which we incorporated into diabetic retinopathy, largely to ensure compliance. Make sure that once you screen, if the disease is not there, it doesn't mean that it will not happen. It could happen 2 weeks later, 3 weeks later. So in order to ensure that we don't miss out any child who we have already made contact with, the software become very essential.
So you can keep tracking actually.
Everything is tracked. Everything is noted. If the child refuses to come, even the reason for refusal is noted. Or if the child goes into some other screening unit, that is also made note of, so that it is at least being screened there. So that's, I think, where technology is helping us more and more to be efficient in what we're trying to do.
So you can have a traveling technician with a camera who goes to all these NICUs, is it?
So again, this is technician-led program. The doctor doesn't get involved until seeing the images. Seeing the images are seen by the doctor. So the technician with a camera, which is a specialized camera, which can image the retina of the babies who are lying down supine position. So the technician who's trained goes with the car. Basically, you need a car and a camera. That's all that you need. And they travel to the different NICUs on a weekly schedule. And all the images are uploaded into the electronic medical records. And all the images are viewed by a doctor who identifies which baby needs to be screened next when, or who needs treatment, and how the escalation process starts off. So this is something which is, we've screened more than about 13,000 babies who are preterm, and more than 60,000 screening sessions. That means most babies undergo multiple
times you have to do.
So around 60,000 screening sessions, and more than 1,000 babies, I think we've been able to do laser or injections and things like that.
1,000 people saved from blindness, from birth.
Yes, I think that's a great achievement for us. When we look back, it's a very fulfilling moment when we see these children walking in and walking out of our clinics now. And we say, look, this might have...
Such an inspiring story.
That's, I think, effort worth it.
Terrific. Thank you so much.
Thank you very much, RamG.
I mean, I don't know how to express the admiration I have for all the programs you guys are running. Just remarkable. Thank you.
Thank you so much for having me here.
Today we have understood what are the gaps that exist in the public health infrastructure and what all needs to be focused on by the government to ensure that millions of people do not go blind in the next few years. This is the health worker.